Pal Singh from ILBS, who will be joining us, and Dr. Sizo, who is also going to join us today uh, in the program. LCAP, and I welcome our dear colleague, Professor Dokmachi from Turkey, for having joined us. The program is uh, on behalf of the APASL, and this is a preceptorship program which is aimed at our clinicians and our practitioners across Asia can be aware of the recent developments and also the algorithmic approach to the management of HCC. And we have two very eminent speakers with a grand round followed by a didactic lecture. So on behalf of the LCAP team, I would like to welcome you all, and I would like Dr. Hasmik to initiate the process. Dr. Hasmik, please.
Please unmute, Dr. Asmik.
So good afternoon, everyone. Nice to see you now. And let us start our session 15, titled Systemic Therapy for HCC. We have two talks in this session, but first of all, I would like to invite Dr. Satenpai Singh. He is assistant professor, MBBC Maulana Azad Medicine College, New Delhi, MD Medicine, Lady Harding Medical College, New Delhi, DM Hepatology Institute of Liver and Biliary Science, New Delhi, Observer Transplant Hepatology, Rela Hospital, Chennai, Q2 Awards, 2021-2022, research interested transplant hepatology, hepatic hemodynamics, and hepatocellular carcinoma, clinical and treatment modalities. Please, Dr. Pal Singh, your nice presentation.
Thank you, Sir, Professor Sareen and Dr. Hasmik for kind introduction. Are my slides visible? Okay, thank you. So the topic is HCC with non-tumoral PVT in advanced cirrhosis. So tumoral PVT is very common. With HCC, it is seen around 10 to 50% of cases. Non-tumoral PVT is also a common issue. But problem is, presence of PVT usually hinders our treatment management in patient with HCC. Sometimes it is non-tumoral, which can be treated with the anticoagulation, which patients might not get if in the required time. Then there is chances of progression of liver disease and development of complications and decompensations. So coming to case detail, so this is a patient, Mr. Sharma. He is a 56-year-old male and with comorbidities of diabetes, for which he was taking insulin and oral hypoglycemic agents. His fasting blood sugar was 126 and HbA1c was 7. He also used to take alcohol. Last intake of alcohol was in 2017. Since then, he is in abstinence. And he first time developed hematemesis in 2017. At that time, he was diagnosed as cirrhosis. There was large grade 3 esophageal varices, no gastric varices. He underwent endoscopy and EVL placement, endoscopic variceal ligation. And on follow-up, there was a repeat endoscopy at every 6 weeks, and thereafter he developed eradicated non-bendable varices. Since then, he is on prophylactic secondary prophylaxis, beta blockers, and he has not bled since then. He is a businessman by occupation. He has presented to us in since 2021, and total duration of current illness is 3 years. His laboratory parameters showed bilirubin total of 1.64 milligram per deciliter with direct of 1.1 and 0.54. Transaminases in the form of AST was 25, ALT was 29, alkaline phosphatase was 81, albin was 4.09, and INR was 1.37, more or less preserved liver function or stable liver functions, with creatinine slightly on the higher side, 1.3, because of the diabetes with diabetic nephropathy component. But he was producing good urine, so there was no indication. There was no indication of dialysis, and he was on medicine and nephrology follow-up. Platelets was 69,000. Tumor markers, AFP was 511, PIVCA2 was 40, lactate dehydrogenase enzyme was 269, and HbA1c was 8. Thyroid stimulating hormone TSH was 1.1. He was not on any medications. He developed ascites when he presented to us. It was moderate and it was mobilized with salt restriction and diuretics. After mobilization of ascites, he underwent cross-sectional imaging. So initially we raised a diagnosis of portal hypertension, bleeder, grade 2 esophageal varices with RCS, cirrhosis of liver, ethanol-related, decompensated with ascites, and acute varicose bleed. So he underwent imaging after mobilization of ascites, and imaging showed on the left side we can see a portal vein thrombosis in the main portal vein. This diagram we can see on arterial phase there is an enhancement in the left lobe of liver suggesting of hepatocellular carcinoma arterial enhancement of around 4.3 into 2 centimeter. There was no intrahepatic portal vein thrombosis, only main portal vein thrombosis. So with the portal vein thrombosis and diabetes and comorbidities, he with single HCC of around 4.3 centimeter into 2 and 1.7 centimeter. He had MELD score of 14. So issues with this patient was portal vein thrombosis. We have to see whether it is a tumoral or non-tumoral, HCC single lesion, child B7, and whether anticoagulation for portal vein thrombosis is required or not. So any comment from moderators? Shall I go ahead? Dr. Hashmi?
I have one question, of course. I would like to know the diameter of thrombosis. Also, you mentioned that your patient used alcohol. Am I right?
Yes, madam, correct.
Which is a contraindication for PVT in alcoholic cirrhotic patients?
Alcohol, cirrhotic patients?
Alcohol used cirrhotic patient. How many contraindication we have for anticoagulation treatment?
Okay. So diameter of portal vein was 17 mm normally for this patient.
Yes.
There was no contraindication as such, but we can see the platelet count. There were 69,000 only. And also patient had esophageal varices for which he underwent endoscopic varicose ligation. At present, he had no non-bendable varices bleed. All the varices were eradicated with endotherapy. Platelet count was 69,000 only. So there was as such no contraindication for anticoagulation, but in view of child B7 status, he has child B7 status. So B7 status is slightly on the higher side of not a preserved liver function as per the BCLC staging.
Thank you. One more colleague. Your diagnosis is metabolic alcoholic associated cirrhosis. Am I right?
Yes.
Your patient is patient with alcohol consumption. Am I right?
Yeah, patient consumption also.
Alcohol consumption, yes?
Last alcohol consumption was in 2017.
Okay.
That
Sorry.
was around
Yes.
7 years back.
Okay, thank you.
I have a question.
Yes, sir.
Thank you very much. This is an interesting case. Actually, the portal vein thrombosis is tumoral or non-tumoral because for the management.
Yes, sir.
What are your criteria to distinguish tumoral or non-tumoral portal vein thrombosis? Because, you know, as you, in your case, alpha fetoprotein is very high, more
Yes,
than
correct.
500. Yes, especially tumor thrombosis has very, very high alpha fetoproteins. And also, actually, DCP and alpha fetoprotein L3 also can help us to distinguish tumoral or non-tumoral portal vein thrombosis. How about your comment about this?
Yes, sir. So I would like to take you to few next slides. So there are features of differentiating tumoral and non-tumoral PVT. So in case of tumoral PVT, there are pulsatile pattern in Doppler. There is a contrast enhancement at the arterial phase, neovascularity within portal vein thrombosis. Diameter of the portal vein should be around 23 mm, and visible hypervascular tumor in close proximity to portal vein thrombosis. In case of non-tumoral portal vein thrombosis, there is no pulsation in Doppler, there is no enhancement, and portal vein diameter also does exceed more than 20 mm. Also, patient with portal vein thrombosis sometimes can have mesenteric ischemia or mesenteric thrombosis. This is just to make it interesting that few imaging you can see is signs of mesenteric vein thrombosis as the edema and target sign. They were not present in this case, but they can be associated with the main portal vein thrombosis. Coming to A vena criteria, which are to differentiate portal vein tumoral from non-tumoral thrombosis. And this criteria was developed and in 467 patients, but the major drawback was there was only 12 of 467 patients who had tumoral PVT. So this criteria was developed in only 12 patients, although it is very famous, but only in case of 12 it was developed. 59 patients has PVT, out of which 12 were malignant. They showed that AFP more than 1000, venous expansion, A vena V, thrombus enhancement, neovascularity, and adjacent to HCC were good enough to diagnose tumoral PVT with ROC curve of 0.97 if they are present more than 3 criteria. So 4 or 5, you can see that they had good sensitivity of around 100%. They are matching to 1. And specificity of 93.6% if 4 and 5 number of criteria are met in case of portal vein thrombosis. So, and if in case of 3, 2, or 1, they were slightly lesser. So, my patient did not had tumoral PVT as per these criteria. Any questions? Shall I go forward?
No, thank you. You can go ahead.
Okay. Thank you very much.
Yeah. So, reason we are here is because of this recent approach, which is called converse therapeutic hierarchy, or concept of multi-parametric treatment. It is recently published in Journal of Hepatology, April 2024. What you can see is there is a one horizontal diagram, multi-parametric, multidisciplinary expert decision, two vertical diagram, vertical bar, therapeutic hierarchy, and conversion or adjuvant therapy. So if the patient is coming to us, we see the HCC, we see whether it is meeting the transplant criteria, and with the help of multidisciplinary expert and a group of team, we see whether he's unfit for it, performance status, extrahepatic. So we stop these if the performance status is bad, extrahepatic invasion is there, adverse biology or location raised AFP, or liver dysfunction or unfeasibility. Then we go for the next step. If these are not our options, next step is minimally invasive liver resection. We also discuss with the multidisciplinary meeting or team whether this is feasible or not. Then we go on the next: liver resection, percutaneous ablation, laparoscopic ablation, intraarterial therapies, systemic therapies, or if anything is not possible, then best supportive care. Now, what is important is, although we do in clinical practice, this is called conversion approach, conversion hierarchy. Patient has come to us with at this stage. So we are doing a procedure, we are doing a TACE procedure to make it transplant feasible and making him go up the ladder here. And then we can go for the transplant. Okay. So we are treating a HCC, we are improving the tumor biology also. We can improve AFP, we can reduce, then we can also make him go up the ladder. So conversion approach or conversion hierarchy therapeutic approach is to make a patient who has come to you in the slightly advanced stage. He is not an ideal patient who has come for the transplant. You are making him better with your therapies, with TACE or systemic therapies, to make it feasible for the future liver transplant. Okay. So another thing which I want to make an comment is BCLC status in advanced stage. As the topic allotted to me was tumor HCC with PVT in advanced stage. So what does the BCLC say? BCLC says that we should give supportive therapy. But what are the limitations? Limitations of BCLC is there that in form of tumor, there is no distinction between intrahepatic or extrahepatic vascular invasion. BCLC staging also does not take into account AFP, PIVKA2. There is no mention of AFP more than 500, less than 500, more than 300, less than 300, whether these patients are transplant feasible or not. There is no also mention of hepatic vein or biliary invasion or in form of liver function. There is, apart from preserved liver function or child status, it does not take into account LB score or MELD score, which is normally followed in every center for transplant patient. We offer patient transplant on the basis of MELD criteria, but it does not include MELD. Patient general and condition performance status 2, if there is there, then it says that patient should be given advanced supportive care. But if the patient performance status is 1, also whether we can make him better to 0 and offer him good therapy in the form of ablation therapy or transplant. Also, BCLC did not mention about any comorbidity or frailty evaluation. So there are some flaws in the BCLC status in case of advanced stages of HCC, which is my topic. We should be moving ahead from BCLC if we want to treat our patient. So, moderator, I would like to know your opinion. What should be the next step for this patient?
Yeah, you can go ahead.
Okay, thank you. So in this patient, we did TACE, trans-arterial chemoembolization. It was a left lobe lesion, which I showed in the earlier slides. So the arterial phase, you can see there is a blush, and after TACE, the blush was not seen, and after embolization, the tumor was healthy. In the repeat follow-up scan, there was complete response of trans-arterial chemoembolization. And next PET CT showed complete response, and AFP, which was earlier 511, now it has decreased to 210, and PIVKA2 has decreased to 32. So in this patient, we had a large tumor with HCC and portal vein thrombosis. We have dealt
Sorry,
a tumor.
may I ask you one thing?
Yeah, sure, sir.
Do you believe that this case, your patient, is beyond the Milan criteria?
No, he's not in below. What important thing was he falls within the Milan criteria, but earlier studies have showed that patient who had AFP of more than 500 at presentation, they have high risk of recurrence of HCC if we do transplant with a bad tumor biology. So tumor biology is important, which I mentioned in this recent paper, and they have shown. The adverse biology or location is also a very important if we are considering liver transplant. So my patient has a P of 511. If we went ahead with the transplant for this patient at that stage, there was a recurrence rate was very high. So we went ahead with the TACE procedure for this patient. Now AFP has come down. It has come down to 210. PIVKA2 is 32, which is falling in the normal range.
I understand that you made a downstaging, right?
Yes, correct, sir. Correct.
Okay. In our center, non-tumoral portal vein thrombosis is not contraindication for the liver transplantation, but alpha fetoprotein level is higher than 500, then we have to make also downstaging.
Yes, correct, sir. So
Okay.
we went ahead, which you already mentioned, with the same procedure. So we went ahead with the liver transplant after the tumor was uh, dealt with the TACE procedure and AFP came down to normal, and patient underwent live donor liver transplant with the donor was son. It was a right lobe graft and single duct single anastomosis. It has been 4 months since transplant, and this is the PET CT which we did as a follow-up protocol after 3 months, and it is showing a perfect liver, no tumor recurrence or no tumor recurrence, and AFP is and PIVKA2 are both less than PIVKA. AFP is normal and PIVKA2 is also normal. So in that way, we downstage the tumor, and we went ahead with the transplant. Important thing was in this case that portal, although there was portal vein thrombosis, which should not be taken as a contraindication for liver transplant, which you have correctly mentioned. And it is also a lesson that every portal vein thrombosis can be uh, should be dealt with as tumoral or non-tumoral. We should have a criteria, and we should offer these patients best approach and best treatment so that they can benefit in the future. Any comments, sir?
The point, this patient had a high PIVKA also, Dr. Satyendra, am I right?
No, sir. PIVKA was 42 only.
In the beginning,
Yes, sir.
only AFP was high.
Yes, sir.
Yeah, so then it means there was a possibility, even in the beginning, to think that it may be non-tumoral portal vein thrombosis. Good.
Yeah.
Please go ahead. Okay.
Dr. Satinder, the
Yes,
presence
sir.
of portal vein thrombus has any impact on the surgery, the transplant, or the pre-transplant? What is the status of the thrombus?
So, main important thing in presence of portal vein thrombosis, the extent of portal vein thrombosis is important because we have to take the graft and we have to join the graft portal vein also. So it was in the main portal vein and it was above the confluence splenoportal axis. So in this case, the anatomy was not peculiar or not contraindicated also. Anatomy was feasible to go ahead with the liver transplant. But as you suggested that if the portal vein thrombosis extending to superior mesenteric or mesenteric vein thrombosis involved, like superior mesenteric vein or inferior mesenteric vein, the extensive mesenteric thrombosis becomes a bad anatomy and would be a risky for going for the liver transplant.
Dr. Singh, thank you for your nice presentation. I have one question. Of course, anticoagulation, and we have also alternative tips. What about your opinion in this kind of patient anticoagulation or tips? Which is your favorite choice?
So, I would like to take you to two abstract. So just this, you already know that anticoagulation is helpful as they, if the portal vein is recanalized and there is a less bacterial translocation and improved survival. So there's no big data in patient with HCC with portal vein thrombosis. I could find only two abstract. This abstract was in 2023, presented in American Society of Clinical Oncology meeting, and they did anticoagulation for portal vein thrombosis in patient with hepatocellular carcinoma. It was a retrospective observational studies in 105 patients. 50% were child B and 46% patients were started with anticoagulation. With apixaban was the most favorable agent they used, and they showed that death was comparable in both group, the patient who were started on anticoagulation and those who did not receive anticoagulation. Also, survival in both group was comparable. And I take you to another abstract, which is also this is also abstract, which was presented in Italian Association of Liver Disease in 2023 annual meeting. Role of non-neoplastic portal vein thrombosis in natural history of patient with cirrhosis and hepatocellular carcinoma. And they showed that overall survival, although was lower in presence of PVT specifically for complete and progressive, a higher cumulative risk of death emerged for complete and progressive PVT. So presence of PVT decreases the survival, but we do not have data for HCC with PVT to suggest that they are helpful. We do have data with the Babino recommendation also that cirrhosis with PVT should be offered for the anticoagulation, but cirrhosis with HCC with PVT, only single abstract is there, only two abstract, and they did not find any benefit of anticoagulation in patient of cirrhosis with portal vein thrombosis. If you ask for anticoagulation in otherwise normal patient, then Babino says low molecular weight heparin should be preferred in patient with advanced cirrhosis. Our patient was B7, child B7. DOACs can be considered, but data is limited. And tips only if the portal vein thrombosis of the main portal vein without recanalization or anticoagulation, especially in patient listed for LT. The question you asked, ma'am, tips can be done if the patient has main portal vein thrombosis and patient is not recanalization on anticoagulation and he has been listed for liver transplant. But this data is for cirrhosis with portal vein thrombosis. They did not include any HCC patient in these. So And we do have also systematic review for anticoagulation in portal vein thrombosis, around 6,005 patients, again in cirrhosis. And they showed the anticoagulation had higher rate of PVT recanalization in patient with 55%, and complete recanalization was achieved in 33%. They might have some bleeding, but it is usually non-varicose bleeding. So clinicians should not be afraid of using as anticoagulation, as the bleeding can be non-varicose and it is usually controllable, only low risk. The indication of anticoagulation in portal vein thrombosis is with recent thrombus, more than 50% occlusion, with or without extension to superior mesenteric vein, if it is a symptomatic PVT. And also anticoagulation should be considered if the thrombus is less than 50%. In case of progression on short-term follow-up, we should follow and compromise the superior mesenteric vein. So these are the Bavino guidelines, which says that these patients can be offered anticoagulation in case of cirrhosis with portal vein thrombosis. And complete portal vein occlusion is a sign of poor survival, and risk of decompensation are higher in case of complete portal vein occlusion. But in case of partial and with the help of anticoagulation, the risk can be minimal, and the future decompensation rates can also be lower. Any comments from the moderator?
Thank you. No, I haven't no comment. But I understand that really portal vein thrombosis is a well-known complication, but until now it is still a matter of debate. Thank you for your presentation.
Thank you, ma'am.
Satinder, one more thing. These
Yes,
cases can be unique because we know SCC is a candidate for a rebleed, and the presence of portal vein thrombosis is also another chance of repeat. So in your patient, he is having cirrhosis, SCC, and portal vein thrombus. So
yes,
when
sir.
you give anticoagulations, how you are going to address the risk of varicose bleed? And two, if you are thinking of going for a TACE or RFA or any local regional therapy like SBRT, what should be the coagulation protocol? Because at some point you have to see that this patient to be anticoagulated and has to go for some intervention liver related.
So this is a 600,000 patient data, which showed that anticoagulation therapy associated with a slightly higher risk of non-varicose bleeding. So varicose bleeding risk is very low, so 2.8% only, as compared to 12.6 to 2.8. And risk of non-varicose bleeding in the form of GAVE or any portal hypertensive gastropathy, they might be higher, but they should not be considered if we are offering them the final treatment. So risk is very minimal.
So this study has having patients with the SCC or only PBT without SCC?
Cirrhosis with PVT, they did not account any HCC.
SCC. Okay. So then, if a SCC patient has no transplant option, you are going for anticoagulation. What should be your endpoint of therapy? It is the
So,
complete portal. Yeah.
so anticoagulation, sir, I told that I could find any single study only. And this study also showed that there is a survival in both anticoagulation in and non-anticoagulation group was similar. So we do not have enough data to say that these patients should be offered for anticoagulation in presence of HCC. This is only retrospective single study. Another study was this also was done with HCC with PVT. They just mentioned that complete PVT is a sign of poor overall survival, but they did not mention that anticoagulation or not. So we have limited data to say that to even tell them that the anticoagulation is choice, and so guidelines or recommendation would come next. We do not have enough data to even give them an option of anticoagulation.
Okay. So if the patient are having ascites, if he is having refractory ascites, then you are not able to treat the tumor because portal vein thrombus has caused the ascites. In that case, how to go for? You have to see that tumor should not progress or tumor doubling time has to be adjusted. And at the same time, you need some time for the anticoagulation to respond for PVT to be reopened. So how to go this situation?
So this would be a personalized approach in case of this difficult case, which you mentioned. If it is an acute PVT, we can every clinician would be following these patients every 3 months for with scan. And if you find a acute PVT, then you can offer them as a 6 months of protocol of anticoagulation, but on personalized approach only with risk. And we can follow, but chances of recannulation in presence of ascites with cirrhosis and HCC would be lesser as one of the earlier studies. So this would be a personalized approach. There is no treatment or rational uh, or guidelines for this particular case.
Okay.
Ma'am?
Yeah, I think, is there any question or comments from audience?
Normally, patients who have got a VP4 thrombus, complete portal vein, they have a very poor, less than 19% 1-year survival.
Yes, sir.
So now the concept of non-tumor thrombosis in HCC is very popular, and the general recommendation is that you can try giving anticoagulant if you think that the PIVCA is not high, and I think what Dr. Satyendra has shown is a good approach. And after the anticoagulation and others, the surgery could also be successfully done. Now we have to see whether the thrombus comes back and how long do we continue with the anticoagulant. So may please continue, Dr. Satyendra.
Thank you, sir. Again, data on cirrhosis with PVT and a single study, I could find that in the fall, the newer anticoagulant, rivaroxaban and dabigatran in PVT with cirrhosis. This was a retrospective study of patients, around 92 patients they have enrolled. Rivaroxaban 15 mg twice a day and dabigatran 42. And recannulation rate was similar, around 75 to 79 patients. And complete recannulation was also 46 to 40%. So novel anticoagulants do offer some hope, but they have been proven good in patient with cirrhosis only, no HCC. And another study which is important because of lower molecular weight heparin, and it was also 91 patient. They also took into account 91 patient, and they gave dalteparin in 82 patient and enoxaparin in 9 patients with median follow of 5.7. They showed the recannulation rate was 61%, but they took complete or near complete 80% occlusion. So their recannulation rate was better as compared to earlier studies. They took around earlier studies took around 70-80%. They took around 80 to 90% biopsy, 80 to 90% thrombosis in the main portal vein. And on that, they showed that almost 61% had achieved recannulation. Complete recannulation was achieved in 22% and partial in 40%. And clinically relevant bleeding was only in 13 patients. 8 patients had to stop. So we have some hope with the with the novel anticoagulants and heparin as a anticoagulation, but still we need data in patient with HCC with PVT, non-tumoral. That's all from my side. Thank you, ma'am.
I have one question.
Yes.
Thank you very much. Actually, I would like to know the age of the thrombosis, because the recanalization is related with the anticoagulant therapy. My question is, the age of the thrombus is important for the recanalization.
So if it is an acute PVT, then of course it is important we can offer them anticoagulation. So in this patient, he was following with the HCC, and every 3 months he was getting followed up. So the thrombus time may be around 2.5 months.
Okay, thank you, Dr. Satyendra. Dr. Hasmik, I think Professor Mark has not joined. So we have to wind up the session for today. So
Yes.
anything from you or Professor Kadir? Otherwise, go.
I think before we wind up, I would like to thank Dr. Hasmik and Dr. Kadir for joining. And also, maybe Dr. Satyendra has done an excellent job, and Dr. Ashok. We do hope that we will have a better audience and better participation in the future. Over to our moderator, Dr. Hasmik, please.
Thank you. Let me say thanks to Dr. Basing for his very nice presentation, really. One more, it is a very well-known complication. Anyway, until now, it is matter for debate. I think in the future, we can have one more presentation about it, because it is very important to manage a cirrhotic patient, especially with hepatocellular carcinoma.
Thank you very much. Thank you, Shiv. Thank you, Hashmik. Thank you, Ashok. Have a good day.
Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye.
Thank you.
Thank you, Izumi, for all the help. Thank you very much. Thank you.
Thank you, sir. Ma'am.
Bye-bye, Izumi.
Goodbye, sir.
Thank you, Dr. Kadir. Thank you. You had
Thank
very
you.
good questions.
Thank you, Dr. Sander. Thank you.